So we briefly discussed the hormones of the HPO axis and how they work together, but now let's discuss them one by one. You will be expected to advise patients on these levels at all different parts of the menstrual cycle. So having a really good knowledge of what these hormones are, how they're produced, what increases and decreases them, when they should be high, when they should be low, is going to be really important as someone who works in an infertility field. So FSH, remember, is secreted by the anterior pituitary gland. It stimulates the follicles to grow, just like its name says. The other things that it does are it induces LH receptors on follicles. So FSH is particularly important for these smaller size follicles. Then as follicles start to get bigger, they start to rely a little bit more on LH that we're going to talk about in a moment. But FSH primes these follicles for LH to then act on these mid-sized follicles. FSH also increases estrogen secretion, and that makes sense because growing follicles start to produce estrogen. And if you have a lot of follicles, like you might in an IVF cycle, that estrogen level gets to be cumulative. So 20 growing follicles that make 100 picograms of estrogen then would be 20 times 100, etc. It also increases inhibin secretion, which is another hormone that acts similarly to estrogen in the menstrual cycle. If we look at FSH on a graph in the menstrual cycle, what you can see is the beginning of FSH starts to have a tiny bit of a peak between day 2 through 4, and then remains low until you have a mid-cycle peak that mimics or mirrors the LH peak. This is not necessarily a clinically significant peak. It sort of gets buried in the LH peak, but if you do test somebody's blood results in the middle of their cycle, you might find an elevated FSH level, and then the FSH continues to remain low. So what we should see if we test blood work on somebody is a low FSH level, with the exception of the fact that if we test it in the middle of the cycle. LH, the other gonadotropin that's secreted by the anterior pituitary gland, also aids in follicular growth. Like I discussed before when we talked about FSH, FSH is really important for the very small follicles. LH starts to become important as the follicles start to grow or become what we call players, those follicles that are able to be fertilized. It increases androgens, and we'll discuss how that occurs when we talk about our two-cell theory. It also, as discussed, causes ovulation to occur. That's what's called an LH surge. That's the hormone surge that precedes ovulation and is necessary for ovulation to occur, either because the person's own body secreted LH or we gave somebody medication that mimics that LH. Sustained estrogen levels, so they have to be high estrogen levels for long periods of time, will cause ovulation, the LH surge, ovulation to occur, and it's one of the few times that the HPO axis becomes what's called a positive feedback system. LH also causes the corpus luteum, that cyst that's left over, to secrete progesterone. And the other thing it does, which will be discussed further in the meiosis talk, is it activates and matures eggs that are frozen in meiosis 1. So meiosis is cell division for sex cells. There are 2 points at which it freezes, and the LH surge, either that person's own LH surge or when we give somebody LH, will induce that first process of meiosis to resume again. So here's a depiction of the estrogen levels increasing, and then them increasing over time causes the LH surge. This is going to be important for you to know for your patients, because if you start checking estrogen levels on a patient and the estrogen levels get to be a certain amount, and you can see that they're going to be a certain amount for a certain period of time, that patient could be ovulating at any moment. So it's really important as a nurse that there's a plan for what to do when that person ovulates. Either they have an insemination scheduled, they decide to go home and have timed intercourse, but absolutely when you see high estrogen levels, you should be suspecting that LH surge to occur and then ovulation to follow. LH on a graph looks like this, kind of similar to FSH, but the surge is a little bit more pronounced. So if you test somebody's blood early or late in the menstrual cycle, what you'll notice is very low levels of LH, until the only thing that when you have the high level of LH is right in the middle of the cycle at that peak. And then if you see what's going on in terms of the ovarian follicles, what you see is that a follicle is ruptured, it's leaving, an egg is leaving the follicle, and then what's left behind after the LH surge, as we discussed, is that corpus luteum. It's important to talk about ovulation in relation to the LH surge. So once somebody has an LH surge, when do they ovulate? And this information is good to know because a lot of patients do home ovulation predictor kits where they urinate either on a strip or a device. So then the patient calls you and says, I wonder when I'm actually ovulating because I've been using this device. And if they're having any kind of timed intercourse or they need to come into the office for a procedure, really that procedure should be precisely timed. So ovulation occurs 24 to 36 hours after the estrogen peak. Remember that the estrogen peak causes the LH surge. So ovulation would occur 24 to 36 hours after somebody just surged. It also occurs, ovulation, 10 to 12 hours after the LH peaked. So in the middle of the cycle when the LH peaked, you can expect ovulation to occur 10 to 12 hours. So if somebody has taken an ovulation predictor kit, usually what they do is they test their first morning urine. And if the ovulation predictor kit is positive, we say that their LH surge occurred. The problem is we don't know exactly when this LH surge occurred. So we have to assume that they could ovulate even 10 to 12 hours from then and be prepared for them to complete their cycle. If we give somebody the LH injection in the office, called the LH trigger, then we know precisely when we ovulated them. That would then cause ovulation to occur 24 to 36 hours after that. And then we would prepare them to be what we call exposed to sperm, either to have an insemination or to have timed intercourse.